So today we're going to talk to you very broadly about a woman's health journey as she ages. We're going to cover kind of every topic you can imagine for the most part, from puberty to menopause. So it's going to be a lot of information. We welcome questions. You can save them for the end, or you can bring them up with each individual section, whatever floats your fancy. So let's begin. So this is the sort of list of objectives we're going to cover today. Again, like I said, pretty broad. Annual exams, screening recommendations, health maintenance, periods, changes with your periods, pregnancy issues, birth control, the sort of perimenopausal phase that happens before you actually hit menopause, a lot of issues that happen during menopause, painful sex, low libido, hormone therapy, urinary incontinence, osteoporosis, heart disease, and then we'll touch base on some nutrition and fitness recommendations. I wanted to just mention to you that we have no financial connection. We're going to talk about some drugs and some products. We have no financial connections to any of these drugs and products. I'm not here to peddle them. I'm just offering them as options.
Okay, so your annual exam is considered your yearly exam. And a lot of us think about our annual exams that we're going to go see our physician or our care provider every year. At your annual health care visit, having an annual health care visit is a great opportunity to take charge of your health. The routine health care visit can help find problems early and can prevent health problems before they occur. So we're checking under your hood and making sure that every opportunity doesn't go unmissed. Also, if problems are found early, they're going to be easier treated, and with early prevention, we can have early treatment. So preventative health care is going to include discussion of all health care topics relevant to your age and risk factors, exams and screening tests, and that's going to be ordered by your provider by the guidelines that are set, and immunizations. And here's our little teen girl driving her car.
We might be exaggerating slightly.
But at least it's a VW. Okay, so we're going to start at the teen years and we're going to work our way forward. Okay, so health topics for a teenage, and many of us have teens in our households. I can raise my hand to that. And so the healthcare topics would include the sexuality, and that's where they're trying to figure out who they are, changes in their bodies, and waiting, and don't succumb to peer pressure, waiting for relations. Sexual behaviors that can put you at risk for pregnancy and STD is another topic that we might talk about when they come in to see us. Contraception is another topic, and Alyssa's going to touch on that a little bit more and in depth down the road here. One of the other topics that is coming up quite frequently is internet and phone safety. It's such a big deal for our kids right now. They don't even realize a lot of times, and even us, we don't realize when we put things out on Facebook and out on the internet how much that can cause you to have issues down the road with people targeting you, especially our teens. Nutritional evaluation, eating disorders, and mood evaluation is also a health topic. Depression and suicide, we've all heard a lot about this right now with our teens. They're at an increased risk. Teens tend to not openly say it, but we'll see the greatest in friends and changes in friends, and they'll start to become very alone and very secluded. And we need to be aware of that for our teen population and our children. Family relations, sometimes they become strained, and sometimes they become strengthened. The teen has personal goals. They want to get through high school, they want to get on with their lives. Behavior and learning disorders. Your relationships, again, with the mental health, emotional and physical, and sexual abuse by a family member or partner. Many times our teens won't talk about that. And we need to sometimes delve into it, and sometimes they'll come openly to a healthcare provider. School experiences, sometimes they'll talk to us about that, what's going on with them in school. Relationship with their friends, how they're feeling about their relationships. Are they being left out of the group? Are they into the group? Acquaintances and rape prevention, it is another thing. You know, you don't have to say yes to anything. And if somebody forces you, it's one of those things that I do meet with my teens about. Don't. If you're being forced to have relations, please talk to somebody. me, Dr. Conklin, anybody that's your mom, your dad, somebody that'll listen. And then this bullying, we all know about it. It's way out in the public right now. We all understand how bullying can really affect our teens. And we're seeing it a lot all over the place, how the teens are turning to self-harm, cutting, suicide because of a bullying situation. This is an opportunity for us during our healthcare visit to talk to them about that and open that door. We also talk about risk factors for heart disease, which goes for many of these things we're going to talk about and we're going to build on as we go. So we talk about in the teen years, we may talk about it in the 20s to 30s, the 40s to 50s, go on that way. So the teen years for the risk factors for heart disease, we want to look at the family history. Many of our teens don't know their family history on this, so we say go home and find out. You want to know this stuff. Who had heart disease in your family? Who has diabetes? The high blood pressure, the cholesterol, obesity. Personal history, some of our teens, our older teens, do become pregnant. And in that case, we have preeclampsia, which is the high blood pressure in pregnancy, and the gestational diabetes. Other topics that we can talk about is use of complementary or alternative medicine over the counter, or if they go down to Apple Valley and find something that they want to utilize to try to be healthy. Hygiene, you want to make sure that they get to a dentist once a year, and we talk about that. We also talk about injury prevention, and that includes exercise and sports and staying safe, weapons and firearms. You know, how many times do we hear on the TV how people are cleaning guns and someone gets shot? It's just what it is there. Occupational and recreational hazards, and protecting your hearing and helmet use, not just riding a bicycle, but motorcycles. We also have driving, safe driving practices with using your seatbelt every time. Click it, click it, click it. And we see it on the TV also. Or you get a ticket. Nobody wants a ticket, especially in your teen years. Skin exposure to the sun. We're in an area where we get lots of sun, love the beach. They should be wearing a good protective, help me.
Sunblock.
Sunblock, thank you. Tobacco, alcohol, and other drug use. We want to talk to them about that and really talk about the tobacco, because this is where kids start to smoke. I mean, it shows that they're independent, we're going to smoke, and we really want to try to nip it in the bud early. Piercings and tattooings, that's another way of expressing themselves, that it shows their individuality. So we're going on then, other than we talk about the risk things and the topics we'll talk about, then the next thing we'll go over is exams and screenings. For our teens, we do a physical exam, which includes a pelvic exam. If they are sexually active. If they're not or not having any problems, we don't do that. Gonorrhea and chlamydia testing, if they are sexually active and have any symptoms, and HIV testing or other STD testing. Immunizations, and as the next title we'll go into on each one of these areas. The Tdap is for the tetanus and diphtheria. The hepatitis B, most of our children are vaccinated early on, usually the first here in the hospital, and then they get their next two during their first months of life. The HPV vaccine is the Gardasil, and that's 3 shots that are given between the age of 9 and 26 to prevent the HPV high-risk virus. Influenza vaccine is encouraged yearly, and there is that time, you know, it starts about October and it goes till about March that we have the flu that's available. The MMR vaccine, the meningococcal vaccine, which is 1 dose if not previously immunized. And if you receive your first dose before the age of 13 to 15, you should get another dose 16 to 18 before you go off the college years. And then the varicella, which you get 2 shots early on for the chickenpox to help with that.
Most of us in this room probably didn't get that vaccine.
You are correct. So here's to
All right.
Dr. Conklin.
So then we also address, of course, puberty itself. Again, obviously this is not exactly relevant to the people in this room, but we all probably have daughters, sisters, friends, etc., nieces. So, so just so that everyone's aware, breasts develop first before you have a period, so that's around average age 8 to 9, then pubic hair next, age 9 to 10, and first period happens around average age 13, range is about 12 to 15. And it's very, very common and totally normal to have irregular periods during the first 3 to 5 years. This is often related to the immaturity of the hormone axis that helps you start your periods. I get oftentimes a lot of teens coming in saying, well, I had a period and then I didn't have one for 3 months, and then I had another one. It's very, very normal. So again, normal periods starting around age 12 to 15. Bleeding lasts around 5 days. We're just talking about normal periods here. Average range 3 to 7 days. Flow can be light to heavy. This can still be normal. Cramps, not really having them or having moderate cramps, and then cycles generally lasting between 21 to 35 days, and this is the start of one period to the start of the next. That's called the menstrual cycle, and all of this is normal. Things that are not normal, if you have too much bleeding, so if you're soaking more than 1 to 2 pads every 1 to 2 hours, that's too heavy. Bleeding between periods is not normal pretty much ever. And periods that happen more often than every 21 days or less often than every 35 days is not really normal. And if you have really severe menstrual cramps, and by this I'm really talking about sort of life-altering cramps, girls stay home from school, you might take a day off of work, this is not normal. There's a list here we'll cover just briefly about causes of abnormal periods, and I can touch base on any of these if anybody has questions. But there's physical abnormalities you can have that can lead to abnormal periods, like polyps inside the uterus, fibroids, which are really just benign tumors in the muscle of the uterus, adenomyosis, which is a word for when the lining of the uterus called the endometrium actually grows and implants itself into the muscle, so very deeply into the muscle of the uterus. So these women often have really bad cramps with their periods. And then cancer or precancer, of course, can lead to abnormal periods. Hormonal abnormalities can lead to abnormal periods, so bleeding disorders. Girls who are admitted to the hospital for really heavy periods, about 20% of them actually have an underlying bleeding disorder. Ovulation dysfunction, so again, going back to what I said earlier about the teens, when the first 3 to 5 years have slightly abnormal periods, irregular, I guess I should say, this is related to not really ovulating because of that immaturity of the hormones. And then if certain medications, hormones, some herbals, and some over-the-counter medications can actually change your periods as well. And again, all of this not normal period can still be really normal. If you have a stress episode, for example, a college student studying for a test might not have a period that month. That's actually pretty normal. All right, so now we're moving on in life. We're in our 20s and 30s. This is like, man, you got your brand new car, you got your sweet career, you might get married, you're starting your family, like you're living your life, right? Okay, so touching base, again, we're going to just build on the whole thing that we discussed as teens because we really address all of these things at every visit, no matter how old you are. We talk about why you're here, your health status, medical history, surgical history, all of that stuff. Family medical history, dietary evaluations, use of alternative medications, because believe it or not, even though these things might be considered safe because you can buy them over the counter, some over-the-counter medications and herbals can actually really interfere with your health. Tobacco and drug use, domestic violence, this is something we all could do better as providers on evaluating patients for. It happens to everyone. I mean, I'm a member of a group of physicians, 50,000 physicians actually, and many of those women are victims of domestic violence. It happens in all realms, all socioeconomic statuses. Everyone is susceptible to this, so it's definitely an issue. Sexual practices can be addressed. We talk about safe sex and ways to be safe. Urinary and fecal incontinence, okay, that's not so much like, let's say, in your early 20s, but if you're 35 and you've had 5 kids, that might be an issue. And cardiovascular risk factors, just as we had discussed in the teenage years. I mean, this is always something that needs to be addressed and evaluated if it's a real problem for a patient. Physical exam, we're addressing your height, your weight, your body mass index. That's the relation between your weight and your height, as that is associated with risk factors as well. Taking your blood pressure, we're doing neck exams, clinical breast exams every 1 to 3 years, beginning at age 20. Abdominal exam, pelvic exam. You don't really need one until you're 21 years old, unless there's a problem. So for example, I have a 15-year-old girl, she comes in, she says, my periods are really abnormal. She started them at age 14. Like we had just discussed, this is actually pretty normal, but it bothers her. We might start birth control pills, for example, to try to regulate those periods or something along those lines. And then if her bleeding is still abnormal, well, now we need to figure that out. And then any other additional physical exams is appropriate. Lab tests, first pap smear is recommended at age 21 no matter what. Some women will have 3, 4 babies by the time they're 21. It still doesn't matter. First pap smear age 21. And then after that, it depends on the test we run. So cytology is a fancy word for the cells along the cervix. So we'll take a sample of the cells along the cervix. That's the cytology alone. If that's performed, it's every 3 years from age 21 to 29. After age 30, we can actually, in addition to that, run the HPV test itself that tests for the virus that leads to cervical cancer. If we do that, that's every 5 years. There's actually some new testing and some new discussion going on with the FDA regarding maybe we should just switch to an HPV test alone. Stay tuned for that.
Do you know that's one of the big changes over the last I won't tell you how old I am, but over the last probably 20 years that I have seen has been the big changes in the pap smear. How do I know when I'm supposed to get it done? I don't even know. I go in and they say, you can have it done every 3 years or every 5 years. And then they say, you don't have to have it at all because maybe you've had a hysterectomy. So it's really hard. This is becoming more consistent in our practice that we follow the guidelines.
Yeah, and it's definitely a discussion we have with every patient as well as far as when pap smear should be done, because some patients actually prefer shorter intervals, and that's fine.
If you desire to have your pap smear done every year, as long as your insurance will cover it.
Honestly, insurance can't keep up with the guidelines. They'll cover it every year. Okay.
We know those secrets.
So health and risk assessments, breast self-awareness, they used to advocate for actual exams. Now it's really just being aware of your breast. So if you notice a change, that's when you bring it up to us. Hygiene, again, dental hygiene as well. Injury prevention and exercise and sport involvement. It's important to stay healthy. Hearing tests when they're needed. Safe driving practices as well. This, especially texting and driving, let's be serious. I'm sure we can all say we've done it. Skin exposure and suicide and depression screenings as well. And again, tobacco, alcohol, and drug use. And then immunizations are all the same to be evaluated as the teen years, except now we're talking about pneumococcal vaccines for high-risk groups and hepatitis A if needed. And other testing that can be done depending on the risk evaluation of the patient. Bone mineral density and colorectal screening. For example, if your mom had colon cancer at age 30, you should probably get a colonoscopy in your 20s. Those kind of things are recommended. So these are additional tests as indicated for the right patient. And then psychosocial evaluation, so we're going through the same stuff we just talked about. Except now instead of school satisfaction, it's work satisfaction. And then now we're getting into the more birth control, reproductive health plan. I mean, obviously that stuff happens in your teens as well. Preconception counseling is something I highly recommend for women who want to become pregnant. That way we can discuss, folic acid supplementation, what that person's personal risk factors are for pregnancy, things of that nature. Okay, now we're going to talk about pregnancy and birth control. So bump ahead. Okay. So as far as getting pregnant is concerned, I thought we could talk a little bit about how your menstrual cycle works, how you get pregnant. I have a lot of women who come into me and they don't actually realize when they ovulate or how to get pregnant. So on an average cycle of 28 days, so again, we're talking about the start of one period to the start of the next, the average person ovulates around day 14. Fertile days, generally speaking, are 5 days before ovulation and the day of ovulation. If they're having timed intercourse, it should be every other day between day 10 and day 20, and generally speaking, they'll catch ovulation. What if you don't become pregnant? So infertility is defined as someone who's under the age of 35 and has gone 12 months or more with timed intercourse and has not gotten pregnant, or 6 months if they're over the age of 35. And that's quite frankly because the hourglass is running out of sand. In a 12-month span, more than 80% of women should conceive. Infertility generally is about 12 to 18% of the average population. Obviously, the older you become, the less fertile you are. So women who are in their late 30s are about 40% less fertile than women in their early 20s. It's pretty depressing. Okay, causes of infertility are listed here. We address ovulation issues. Is there any history of tubal scarring or surgery? There might be male infertility. Endometriosis can lead to infertility. Sometimes women and the couples just don't have adequate timing of intercourse. Like maybe they're only having sex once a month. Well, that's probably not going to cut it. And honestly, 25% of the time, we don't know why people are infertile. Lifestyle factors can help. So if you smoke, quit smoking. Achieve a healthy weight and avoid caffeine and alcohol can sometimes help. And then the question has often come up, how often or when should you have another baby? So actually the WHO and the United States Agency for International Development recommend an inter-pregnancy interval, 2 to 5 years. So that means the birth of one baby to the conception of the next. Now let's all be serious. There's a lot of women who don't follow that. The risk is if you don't follow that, it increases the risk for preterm labor, breaking your bag of water early, growing a smaller baby, or having placental insufficiency where the placenta can't feed the baby well enough. But I can't even think off the top of my head a single patient who's actually fit that criteria. But there's the recommendations. When you become pregnant, we advise starting prenatal care in your first trimester to maximize health during the pregnancy, and also prenatal vitamins are free at Meijer. So, all right, so birth control. Do not enter. Let's talk about birth control. I'm going to briefly address, for the most part, every type of birth control you can imagine. If anybody has questions, feel free to bring them up. I just didn't want to delve into too much detail with each one. But I thought we'd talk about them all. So Nexplanon is an arm implant. Mirena, Skyla, and Paragard are all different forms of intrauterine devices that go inside the uterus. Ortho-Evra is a patch that you can wear. I believe that's actually coming off the market, and a new one is now called Xulane with an X. Combination oral birth control pills and progesterone-only birth control pills are options as well. NuvaRing is a little plastic ring that actually goes into the vagina. And Depo-Provera is an injection that you receive. Is that pretty clear? Oh, wait. It's not very clear. So, all right, let's get into more specifics here. So who should take birth control? Basically anyone who could become pregnant really should probably be on some sort of birth control. 49% of pregnancies are unintended. I would love to drop that statistic. So what are the side effects? What are the benefits? And how effective are they? That's what I'm going to talk about here for just a few minutes. The most effective, obviously, are the ones you don't have to think about. So the arm implant and the IUDs, very effective. Mostly effective, Depo, birth control pills, basically everything else. The problem with those, of course, is that you have to remember them in some interval. This is a pretty decent graph, mostly for the comparison's sake. So for example, down at the bottom here, I don't know which one you guys are looking at. Where's the little arrow? So 85% of the time, women will become pregnant if they use nothing. Then you've got the more effective ones here. So the IUDs really I don't agree with the statistic here, but the comparison is what I'm really honing in on here. So the IUDs, you see all this stuff. The implants, less than 1%, right? Female sterilization, male sterilization. Then you get down here, talking about, male condoms. Okay, so perfect use, 3%. Typical use, 14%. Not super effective. Spermicides, withdrawal method, depending on participation. Not the most effective. The Nexplanon looks like that. It's a 4-centimeter soft, flexible arm implant. It lasts for 3 years and secretes progesterone during that time. The failure rate is 0.05%. This is actually technically more effective than getting your tubes tied, which to me is crazy. I've never seen anyone pregnant with it ever. There was actually a study that I read where women had it in place for actually 4 total years instead of 3. 700 women and not one was pregnant. Biggest side effect, though, is irregular bleeding. This is actually fairly common. 10% of the time, women actually want the implant removed because the bleeding is so bothersome. But that means 90% of the time, women are very satisfied with the bleeding pattern and accept it. Those other side effects are listed, but they're very uncommon. This is what the Mirena IUD looks like. It's, again, another plastic device. It's a T-shaped device. It goes inside the uterus. All these are implanted in the office. It can cause cramps while it's inserted, but generally well tolerated. It can last for up to 5 years, but it could be pulled sooner. For example, if a woman wants to get pregnant or does not like the IUD. Failure rate less than 1%. Side effects, irregular bleeding, decreased bleeding, and here's my favorite. No bleeding. That's a good one. A lot of women actually stop bleeding altogether while they have this in place, and a lot of women enjoy that side effect. Skyla is a very similar device. I believe this was actually developed very recently. This wasn't here even in 2012, where it's slightly smaller than the Mirena IUD, and the insertion device is slightly smaller. So I think a lot of women kind of go for that one if they haven't had a baby yet. I personally don't see it's much different inserting it. Anyway, it lasts for 3 years as opposed to 5 years. Similar kind of concept. It secretes progesterone into the lining of the uterus, keeps it thin. Often women don't bleed or have much less bleeding, and the failure rate is less than 1%. And then here's the Paragard. This actually has no hormones in it at all. This is the only, aside from condoms and getting your tubes tied or vasectomy, the only non-hormonal form of birth control that's on the market. So this IUD goes inside the uterus again like the others, copper only, and it can last for up to 10 years. Generally speaking, women have the same periods they've always had if they have this IUD. There's 2 to 3 months in the beginning where it might be heavier and more crampy than not having it, but generally very, very well tolerated. Depo is an injection that you get in your arm or your bottom. It lasts for 3 months. Failure rate is also, again, less than 1%, as long as you remember to get the injection every 3 months. Side effects, irregular bleeding, changes in libido, and weight gain is probably the most common one that I hear from patients. I have seen all of these, though, depression, hair loss, and headache as well. Ortho-Evra, or Xulane, as it's soon to be called, is that sort of life-size picture there of the patch. You can put it on your shoulder or on your hip. You generally rotate it once a week, and then you take it off on the 4th week to have a period. The big important one about this is that on women who weigh 198 pounds or more, this has been studied to actually be less effective. So it's not advised for someone who weighs around 200 pounds or more. The NuvaRing is a vaginal insert. I can rarely convince patients to try this. Usually patients come to me saying they want the NuvaRing. That's about how big it is. It is inserted into the vagina and stays in the vagina for 3 weeks. You can actually have intercourse with this in place as well. And then every 3 weeks you take it out, have a period for a week, and put a new one in. Generally pretty well tolerated. There are thousands of combination birth control pills. These are just a few samples. You have to take them every day. That's probably the biggest drawback to them, but they're very well tolerated as well. Nothing is injected into you. Nothing is put inside your uterus. Most women don't bleed in the middle of these packs, just during their placebo week or the period week. Depending on the use, the failure rate has a pretty wide range, 0.1 to 5%. Again, you forget a pill, you could get pregnant, so you have to remember it every single day. Side effects, breakthrough bleeding, especially if you don't remember to take your pill on time. Headache, nausea, bloating, sort of pregnancy symptoms essentially, but also very well tolerated. And these are progesterone-only pills. You can see the difference is that these pills are the same color the whole month. So there's no placebo week. These pills are hormonal every day. These are generally best for women who are breastfeeding or women who have contraindications to taking estrogen. So failure rate's very similar to the regular birth control pills, and they might be slightly less effective. So I tell women who are on these pills to set an alarm and take them at the same time every day. So is that pretty clear? Okay. So moving on. Now we're in the 40s and 60s. Okay, so you've got like your really established career. You may have like the coolest car you've always wanted. You're moving on in life, right? Okay. So you can see we're whittling down what happens at an annual exam. So that's the same as we've previously discussed, except now prolapse can be an issue for patients. Incontinence as well, and menopausal symptoms are happening. Labs and other tests that we do, same as previously discussed, except now we're talking about diabetes testing every 3 years after the age of 45. Lipid profiles, so that's your cholesterol panel, every 5 years after the age of 45. Hepatitis C testing, this is a one-time recommended test for anyone born between 1945 and 1965. Yearly mammograms, that's debatable, okay? It depends on who you ask. I generally, and ACOG generally recommends a mammogram every year. The American Cancer Society has changed that recommendation to every other year in your 40s, and some, I forget which group, has recommended it now starting only at 50. So between the 40s and 50s, I have a conversation with patients and leave it up to them as to what they choose for their mammograms. After 50, every year. And then colorectal screening, especially over the age of 50, that's when your first colon screening is recommended, unless you have risk factors otherwise. And then we talk more about advanced directives. Aspirin prophylaxis, so if you're between ages 55 and 79, it's recommended that you take an aspirin every day to help prevent stroke. And then hormone therapy, if that becomes an issue, a discussion happens about that. And the herpes zoster vaccine, if you haven't taken it and you're over age 60. So now let's talk about menopause.
All right. Are we there yet? Navigating now with our guided menopause tour. The Menopause Journey. How many of us here have decided to go on it? None of us decided to go. Not one of us, but we're going on it. There's no clear starting point or ending point. There's odd diversions along the way. There's the estimated time of arrival that could span for years. You could start at 30 and still be working on it when you get to 60. Menopause is certainly a trip. And needless to say that you can use some turn-by-turn directions. There is no rules here.
Especially if you're that lady.
Yeah.
I mean, they even put good luck on that road sign.
Okay, so our first point of interest, we're going to stop and do perimenopause. That's before menopause happens. That's the getting ready point. So in this phase, your body will start providing helpful physical cues of menopause is starting. And it can be years before the last menstrual period. So you can start this several years before you really go into menopause. Some common normal signs include irregular periods, hot flashes, vaginal dryness, sleep disturbances, and mood swings as a result of uneven changing levels of ovarian hormones, the estrogen, and that's in your body. So that's why we go through this, or at least it starts. And you could still be bleeding, and until you have 12 months without bleeding, you're in perimenopause. So when you start seeing those symptoms, that's where you're at. So a pit stop, check your contraceptive options. In perimenopause, we can get pregnant. It's just what it is. So we want to make sure that you're covered and well covered before you go right into menopause. One of the great things, as Dr. Conklin went over, is the Mirena IUD. With dysfunctional uterine bleeding in the 40s and 50s, we offer that as an option to help with this bleeding periods and that. So it also gives you the contraceptive option too then. Gives you coverage. Effective options for midlife women include all the discussions as well as the sterilization that we talked about, the tubal ligation, the fallopian tube inserts, which is called the E-Sure, and it's two little wires that go into the fallopian tubes, and then the vasectomy for the men. Barrier methods, again, she did go over the really not that effective ways, so condoms, diaphragms, and spermicides. Little detour here, this happens sometimes a little bit earlier, right around in their 40s, between 30s and 40s, primary ovarian insufficiency. It's one of the things that can get you to menopause earlier, and it's not a condition that we see often, but we do see it, where women under the age of 40 have little or have no or only occasional periods with elevated follicle stimulating hormone. And what it does is it signifies fewer eggs in their ovaries, and some women with a POI have typical menopause-related symptoms, okay? So what it means is that you have lower estrogen levels, and it means a negative effect on your bone density and possibly your brain and sexual function. So timely diagnosis is a key. So if it sounds like this is you, you need to make sure that you tell your healthcare provider, and we can check for that, especially earlier than 40. So we're arriving at our destination of natural menopause, and so here we are, and the spontaneous permanent ending of your menstruation. That is not a cause of any medical treatment. And what that means is that you haven't had a period for a year. Done. And you should never bleed after 1 year. So you should mark when you have your periods, when it's finally done, then you should never bleed again. If you do, you need to see your healthcare provider. Menopause is a normal natural event. It's defined as the final menstruation period and is confirmed when a woman, again, has not had a period for 12 months. Women in North America will likely experience natural menopause between 40 and 58, averaging about 51. Some women, however, reach this phase earlier in their 30s, others in their 60s. That's where we don't know when it's going to happen. Typically, women reach menopause at the same age their mothers or sisters did. One little triptych is that smokers tend to reach menopause a couple years earlier, while race and age of the first period, use of birth control pills, and other fertility medications don't seem to be a determining factor. So recalculating menopause, the final stop along our midlife tour is post-menopause, okay? Well, I didn't read that right. This phase includes the time after menopause, and it still manages to muster up a surprise or two. Due to the continued decreased amounts of estrogen levels during this time, the symptoms like vaginal dryness and hot flashes may continue on. Lower hormone levels also increase your risk for related diseases like osteoporosis. So,
all right,
Miss Seven Dwarfs.
Now we're going to talk a little bit more in detail about some of these issues with menopause. All right, so you guys all know that Johnny Cash song, right? I fell into burning ring of fire. Okay. Anyway, so well, I hope it sounded good. Okay. So painful sex, that's a huge drag. This is not something that you wake up one day and just have. I mean, this is something that slowly becomes a real problem. It's related to vaginal atrophy and lack of estrogen that happens during that transition as the estrogen levels go down when you are transitioning into menopause. You end up with a lack of natural lubrication, so a lot of these women really need support with store-bought lubrication during that time. And honestly, 70% of women do not volunteer this information with their healthcare provider. So this is something that I bring up, at every visit. They're coming in for the annual exam. Oh, by the way, and this can become a whole new problem visit with this. There's a lot of treatment options. Some of them are okay to take, and some of them are not. For example, if you've got a history of breast cancer, you can't take estrogen. So there's estrogen therapy, lubrication such as Astroglide is my go-to for menopausal women. This is a very nice, natural-feeling lubrication that you can get over the counter. And believe it or not, olive oil that you have in your pantry and coconut oil work wonders. And then there's actually a new device, procedure, I guess we should call it, called the Mona Lisa Touch that we can talk about. Oh, look, we're going to talk about right now. Okay, so this is a procedure done in the office that is using CO2. It involves 3 short treatments that are about 5 to 10 minutes each. They happen at approximately 6 weeks intervals. There's no downtime, there's minimal side effects, there's no anesthesia, so it's actually pretty neat. I'm not certified to place this. I've never used it. I've actually Googled where this is at locally. There's some in Chicago. There's some in Valparaiso, I think is the closest. It'd be nice to bring it here. This is exceptionally awesome for women who've been through breast cancer because they can't have estrogen. And you see these pictures here. I will show you pictures of what it looks like to treat your vagina with estrogen, and it is basically the exact same thing. So on the left here on this picture is sort of what your vagina looks like in menopause, this sad purple little layer here. And then you get the Mona Lisa touch, and even after one treatment, it does this. So what it actually does is the CO2 laser creates little microabrasions in the vagina, and it essentially teaches your body to repair itself, and it ends up doing that. So that's pretty amazing, actually. Unfortunately, insurance, which has always been behind the 8 ball for women's treatment, is not covering this treatment. Hopefully they will someday. So to get these treatments, the total cost is between $1,000 and $2,000 out of pocket. And then they do recommend that after you do this initial 3 treatment protocol, that you get 1 treatment every single year thereafter to maintain this nice, healthy, premenopausal vagina. Other options, I'm going to list a few of the estrogen-containing options. So here on the left, we've got the yeast ring. This is a plastic ring that actually is placed into the vagina, and it can stay within the vagina for 3 months. So you would take it out and replace it every 3 months. That's nice for women who don't like the creams because they, could be messy or don't feel comfortable putting something in themselves all the time. We even have some older women who will place that ring for them, and then every 3 months they come in and we'll do it for them. When you have painful sex and vaginal atrophy and symptoms from it, and you use these estrogen therapies, 80 to 90% of women notice a difference and improves their lives dramatically. Local estrogen therapy has minimal side effects and doesn't really get into the bloodstream. Several well-designed studies showed that women who use these products had similar blood levels of the estrogen in their bloodstream as did women who didn't use them at all. So all these products we're going to show you have basically the same indication. I just wanted you to be aware of what's optional. The estrase cream, sorry, I should probably tell you about the cream. So the estrase cream on the left, and I'm going to show you Premarin. Those are both brand name estrogen creams, both the exact same indication. I really don't care which one you use, is whatever your insurance will pay for. And so this is generally used, everybody does it a little bit differently. There's 2 options. One is to take it every single night for 6 weeks into the vagina with this applicator, which is similar to if you've ever treated yourself for yeast infection. The applicator gets placed into the vagina and the medication gets placed that way. And you can either do this every night for 6 weeks and then twice a week forever, or just start out doing it twice a week forever. The studies have shown that when you get to the 12-week mark after treating with the estrogen cream, both of those patients have the same outcome. So it just depends on how quickly you want to get there. And that's Premarin here on the left, similar to estrase in its concept. And then you can see these pictures are basically the same I just showed you. So on the left is your sad menopausal vagina, and on your right is that nice, very thick, very stretchy, lots of elastic tissue vagina. Okay? And on the bottom here is VagiFem. This is a tablet that you can place in your vagina. A lot of women, if their insurance will cover it, enjoy this just because it's less messy. Honestly, the creams aren't that messy either, but the tablet is just a tablet. Same use. Okay, Osphena. So this is an interesting drug. It's similar to tamoxifen, which is a drug that women use to treat breast cancer, if you've heard that name before. It has estrogen-like effects in the vagina without stimulating the lining of the uterus. So if you take estrogen alone and you have a uterus, which we'll talk about in a little bit, it does increase your risk of cancer inside the uterus. So you can't take estrogen alone orally, or it can increase your risk of cancer inside the uterus. So this drug helps with that. It helps with the painful sex related to vaginal atrophy for menopause. There are no studies to say whether or not this drug would be safe in women with breast cancer, which is really sad because I have a feeling it probably is safe. Nobody's just conducted the studies. So at this point, we can't really prescribe this for women who've had breast cancer. But I would love it if they would conduct the study. There's a lot of women who could benefit from this. The most common side effect from this drug is actually hot flashes. So if you have hot flashes and vaginal dryness, this is probably not the drug for you. Okay, so hormone therapy. Nobody likes hot flashes, right? Especially fish. So what is hormone therapy? Hormone therapy involves estrogen and progesterone to treat hot flashes, essentially. A lot of women are very resistant to this because of the Women's Health Initiative study that came out in 2002, so we'll talk about that in a second. So you either take estrogen alone. If you don't have a uterus, that would be what you would take. If you have a uterus, you have to take the progesterone in order to help prevent cancer inside the uterus, but still giving you the same benefits of the estrogen. But wait, doesn't it cause heart attacks? Because I'm pretty sure that's what I heard. Okay, that's what I hear a lot. So the Women's Health Initiative study was a humongous study. It actually had 161,000 women in it. 27,000 of them were put on hormone therapy. It was a much broader study looking at many other things. And those women who were on hormone therapy, the study was actually stopped early because women were found to actually have increased risk of heart attacks. It showed increased risk of heart attack, stroke, blood clots, and breast cancer. And so after that, I mean, there was a mass exodus of women off of hormone therapy because everybody was afraid they were going to get in trouble. The problem was this study had women who were over the age of 65 and or more than 10 years away from the start of their menopause, whereas the general population, women who start to enter menopause, those are the ones who have symptoms, right? Those are the ones who want the treatment immediately after menopause, not 10 years later. Okay, so the sort of breakdown of what it showed was that estrogen alone increased your risk of blood clots, like in your legs and lungs. And the benefits was that it could help with heart disease, breast cancer, stroke, colon cancer, fractures, diabetes, and all-cause mortality, which is sort of a wastebasket diagnosis of anything that could possibly kill you. Estrogen and progesterone is the arm of women who took it who had a uterus, because you have to have that progesterone, and it showed even more risks and some benefits. So what does that really mean? What that really means is, as far as the risk for you, if you chose to go the hormone therapy route, and this is a conversation we have every time a patient comes in wanting this. So if you take 1,000 women over the course of 5 years, how many more heart attacks are you going to have, right? So for example, if you take estrogen alone and you take 1,000 women over the course of 5 years, you're going to have 1.5 more cases of blood clots in the lungs, half of an additional case of a stroke, and 5.5 fewer deaths from all-cause mortality, okay? So that's not a huge risk, right? If you're taking estrogen and progesterone together, again, taking 1,000 women over the course of 5 years, you're going to have 2.5 additional cases of heart disease, 3 additional cases of breast cancer, 2.5 additional cases of stroke, 3 additional cases of blood clots in the lungs, a half of a fewer case of colon cancer, and 5 fewer deaths from all-cause mortality. So, in general, the benefits appear to outweigh the risks with regards to taking this medication in most women who have symptoms of menopause with hot flashes. Generally speaking, you want to use this, I think I might have said this on the next slide. So ideally, the lowest dose possible for the shortest amount of time. So the recommendation is really less than 5 years. That being said, I have 80-year-old women on hormone therapy. I mean, if they're not going to leave the house because their hot flashes are so bad, that's not life. So every individual patient is taken, obviously, individually with regards to what is best for them. And the general gist now, so the Women's Health Initiative was created to help identify, hey, if we put these patients on estrogen, maybe they won't have heart attacks. And then found quite the opposite. So the bottom line was, don't take this medication to treat, your family history of heart disease because you don't want to have a heart attack. Only take it if you really have life-altering hot flashes, mood swings, night sweats, things like that, okay? And again, taking into consideration your personal risk profile. And I did want to mention that you don't have to take hormone therapy, obviously, at all. An alternative for that is antidepressants. This has been pretty well studied. Antidepressants do improve hot flashes and mood swings and night sweats as well, without the risks of estrogen. Okay, so low libido. Female sexual dysfunction takes different forms, including lack of sexual desire, impaired arousal, inability to achieve an orgasm, or pain with sex, or a combination of all of the above. So sexual desire naturally fluctuates, especially for a woman. Pregnancy does it, menopause does it, having an illness does it. 40% have sexual concerns, but 12% are really distressed by it, and so that's where it really becomes an issue for that population. There's a lot of causes. I've listed many of them here. Some medications will do it, some medical conditions will do it, lifestyle habits can do it, and obviously relationship issues can do it. Treatment is multifactorial, shall we say. There's no magic pill. I will talk about a pill, but there's no magic pill for this. There's no Viagra. So estrogen therapy can help, hormone therapy depending on the patient. Sex and couples therapy I advise for everybody who's got an issue. Pelvic floor therapy depending on your issue. If you've got some issues with the pelvis, that's helpful. Treating incontinence is a big issue. A lot of women have incontinence actually during sex, and so that becomes the chicken before the egg situation. A lot of women don't want to have sex because they're afraid to be incontinent, and it's not attractive. And lifestyle changes, and then testosterone. So this is an interesting one. Levels in the testosterone in the bloodstream don't correlate with sexual function or sex drive in women, contrary to what a lot of people think. There's no FDA-approved testosterone for this purpose due to limited clinical data, so there just haven't been a lot of studies, and limited effectiveness when you compare it with placebo. So if you give women 2 creams and you don't tell them which one's testosterone, there's a placebo effect you guys have all probably heard of. It's primarily reserved for a woman who has low libido associated with this stress, who has no contraindications to testosterone therapy, and is otherwise physically and psychologically healthy and in a good sexual relationship. I mean, that's hard to figure out, right? Typically, she's already tried other safer interventions prior to testosterone prescription, including low-dose vaginal estrogen, relationship interventions like sex therapy, date nights, use of sexual aids, books, and adjustment of any antidepressant medication if you're taking it. And side effects include acne, facial hair, deepening of the voice, bad changes in your cholesterol testing, and a possible increased risk of breast cancer and abnormal uterine bleeding. So it's not something to take lightly. Okay, and then this is the one I wanted to tell you about your magic pill. I don't know if you guys have ever seen this commercial on TV for Addii. So this is not for menopausal women. This is for premenopausal women. Addii is a brand new pill that's supposed to be the pink Viagra that just came out for hypoactive sexual desire disorder. It's a non-hormonal prescription pill approved in August, actually, to treat this condition. And it's for women who haven't gone through menopause, like I said. Hypoactive sexual desire disorder is when a woman has low sexual desire disorder that causes a lot of distress or interpersonal difficulty and is not due to the coexisting conditions we talked about. So for providers to prescribe this drug, this is actually very difficult. I'm not certified to prescribe this drug. You have to go through special training. It's only available through what's called the REMS program, which stands for Risk Evaluation and Mitigation Strategy. So physicians and pharmacies have to go through a special training program in order to prescribe it or dispense it, which is fascinating. You can't take this drug if you drink alcohol because you can have life-threatening low blood pressure. And you actually have to sign, patients and physicians have to sign like an agreement about all of this. I mean, it's pretty intense. It's like under lock and key. Common side effects to this drug include dizziness, sleeplessness, nausea, fatigue, insomnia, dry mouth, anxiety, constipation, abdominal pain, spotting, on and on, right? Rash, sedation, and a spinning sensation called vertigo. So it's not exactly pink Viagra. And then Wellbutrin, actually. So this is an antidepressant drug. Some people even use it to help quit smoking. I don't know if you guys have heard of it for that reason. In one study of 75 premenopausal women who had low libido and did not have depression, many of these women reported increased sexual desire and sexual pleasure. So this drug, for example, if a woman has depression, adjustments can be made when possible to put the patient on Wellbutrin instead, for example, if they have hypoactive sexual desire disorder that's distressing. And other women can actually have that condition treated with Wellbutrin without having depression. So that's actually, sort of in my opinion, a better drug. Okay. Urinary incontinence. Who wants to talk about that, right? Okay. Get it? Incontinence hotline. Can you hold? Okay. So this is, you cough, laugh, sneeze, and you leak urine. Or you have an urge to go to the bathroom and you leak on the way to the bathroom. Not fun. 25 to 60% of women seek care for this, and this happens, of those women, a third of the time actually have symptoms during sex. So again, then this becomes the chicken before the egg. Did you have lack of sexual desire before you had incontinence, or did it happen first? Associated problems, you can get yeast or skin infections from the constant moisture and exposure, falls and fractures. If you, oh God, I have the urge to go to the bathroom, and you get up and run, you can fall and hurt yourself. Risk factors for this, obese women are way more likely to have urinary incontinence than non-obese women. Having given birth in any fashion, so not just vaginal birth, C-sections as well. Smoking and having menopause and vaginal atrophy can also increase the risk. So obese women 3 times as likely to get incontinence than non-obese women. And if you lose weight, such as bariatric surgery or just changing diet and exercise, 50% reduction in incontinence symptoms for those women. And other risk factors are listed there. Caffeine is actually quite a bladder irritant. So if you have a lot of urgency to go to the bathroom, dropping your caffeine level or completely stopping it is beneficial. The types of incontinence: stress incontinence, urgency, and overflow. Overflow is where you have continuous leakage. Urgency is, like I said, you get the urge to go and you leak on the way. And stress is when you exert yourself in some fashion and leak urine. Jumping on the trampoline will do it. Okay. So treatment, all types of urinary incontinence can benefit from all of the things I just listed and talked about. Weight loss, dietary changes. If you're constipated and you're bearing down a lot, that can be a huge problem. Reducing alcohol and caffeine and carbonated beverages, because those are all bladder irritants. And if you're somebody who drinks a lot of liquids, like 64 ounces per day, you can decrease that intake, and that can help a lot with incontinence. Kegel exercises, a lot of people talk about them. Not a lot of people seem to know what they are. So this is where you try to hold your urine in. It's best practiced, in my opinion, when you sit on the toilet while you're trying to pee, and you stop your urine flow. Then you're using the right muscles. So 8 to 12 contractions of those sustained for 8 to 10 seconds each, 3 times a day. And that's Kegel exercises. And pelvic floor therapy, I don't know if you guys know this, but there are actual physical therapists who are certified in pelvic therapy. So these people don't do your arm muscles or your leg muscles. They focus on the muscles of your pelvis. You would not believe the amount of stuff they have to help your pelvis.
And we have that program here at Lakeland. Mm-hmm. I've got some information in the back too. So
if you have stress incontinence, the 2 main options besides doing nothing is surgery and pessaries. I'll show pessaries here in a minute. Surgery involves various types of surgeries to help decrease the amount of leakage. In urgency or overactive bladders, those are primarily treated with medications, but they're not without side effects. So dry mouth, dry eyes, constipation, things of that nature. And you can't take it if you have problems emptying your stomach or if you have ankle closure glaucoma. And then there's something called a sacral modulator. I am not certified to place this, but I have seen it placed. This is actually a device that gets implanted underneath your skin, and those wires get led into your sacral nerves in the back, sort of lower backbone here. And they stimulate your nerves to basically, crack the whip on your bladder. It's a staged procedure, so you have one part of the procedure is done first, where they practice stimulating the bladder to make sure this is actually a legitimate thing, and then you come back later to have the actual device implanted. These are pessaries. They're scary looking. They go in your vagina. They help with stress incontinence and also prolapse. We didn't go into prolapse because, let's be serious, there's a lot to talk about. But I'm happy to talk to anybody about prolapse. Okay, now you're 60s and older. I might be exaggerating here a little bit too.
I love that picture, actually. Okay, again, the history and exam, back to where we started at with everybody moving on. The same exam, except your pelvic exam. When a woman's age or other health issues are such that she's not choose to intervene on conditions detected with a routine exam, it's reasonable to discontinue pelvic exams. You don't have to have a pelvic every year, and it's just, you don't have to do it. One of the things we do add to the exam, though, is you need to be seeing your eye doctor for visual acuity and glaucoma assessment. 60, again, the PAPs. Age 65 and older, you can stop your pap smears if you have negative results 3 times in the last 10 years and no major cervical abnormality in the last 20. So we can be done with that. Urinalysis, this is something after the age of 60 that I would encourage women to do yearly, because sometimes we don't even know we have a UTI going on, and it's just a hidden, and then, like me, you might act a little crazy, and then all of a sudden you've got this raging UTI.
It's actually one of the most common reasons why older women are admitted to the hospital with sepsis.
Yes, exactly. So you really, isn't that something? It's really important to detect that, and many times we can't tell with the burning. It's more the frequency and sometimes the odor of your urine. Advanced directives, we didn't really touch on that before, but I'm going to touch on it now. Here at Lakeland, when you come in, they ask you about your advanced directives. Do you have an advanced directives in place for health care? It is something, as we're hitting between the 40s, 50s, and 60s, we really want to have so that our family knows our wishes. One of the other things that we didn't touch about, and I was going to add this in somewhere, is organ donation. You need to talk about your family. If you are an organ donor, even though it says it on your card or your license, if you have one family member that disagrees, they will not harvest your organs and donate after you're gone. Depression and sleep disorders, lots of insomnia for all of us in the postmenopausal area. Family relations, abuse, neglect, and lifestyle stress. Back to Alissa.
So osteoporosis, this is a big deal the older you get, of course. You can see in this cartoon a nice normal spine bone. Look how nice and thick that is, and then this sad little osteoporosis spine bone. It's not a good thing. It's 5 times more common in women. It's pretty expensive. It costs the country $17 billion a year in osteoporosis-related fractures. Of women admitted to the hospital with a hip fracture over the age of 80, 50% will not be able to walk independently after a year. And 3 to 6% of women will actually die in the hospital with their hip fracture. My grandmother just had one, actually, and made it, and can walk. Okay, so the important thing about osteoporosis I really wanted to stress in this talk is that your final peak bone mass actually occurs around age 19. Who's thinking about that when they're a teenager, right? So also, when you get into menopause, that's the time of the most rapid bone loss. It's about 6 to 7% of your bone loss beginning 1 year before the end of your period and continuing for about 3 additional years occurs in that very small amount of time. This is diagnosed by a DEXA scan, which stands for dual energy X-ray absorptiometry. Treatment is primarily prevention, which we'll talk about in a minute. And then, of course, this is like Sally Field selling Boniva, right? This is the bisphosphonates. That's the drug category of women to treat osteoporosis. I listed all of them there. If you have osteoporosis and you take this drug, it reduces vertebral, which is your spine, risk factors by 35 to 65%. So it's pretty helpful, but it's very specific how you take it. You have to take it on an empty stomach with a full glass of water and sit or stand for 30 minutes. Kind of bizarre. Okay, this is a really good slide. So these are the calcium and vitamin D recommendations based on age group. And clearly, if your peak bone mass ends at age 19, this is really important. So if you have, daughters, granddaughters, you should definitely be getting them on calcium and vitamin D. I see everybody writing this down. If you want me to, I can print these out. And if you guys leave your email addresses or addresses, I can get them mailed or emailed to you, this slide. And any other slides you want. But I like this one because it really just summarizes it for everyone. Do you guys want me to wait for a second?
And vitamin D in Michigan, we lack.
Yeah, it's been a long time since I've seen a normal vitamin D level, actually.
We don't get enough sunlight.
Okay, so there's two more topics I wanted to discuss before we're done. One is heart disease, the other one is nutrition and fitness. Heart disease is relevant to everyone, of course. 1 in 4 women will die of heart disease. Narrowing of the coronary arteries is the #1 cause. I thought this was fascinating. So broken heart syndrome is actually a real thing. How many people have heard of like a husband dies and then a week later the wife dies? Okay, that's like legit. This is a cardiomyopathy, which is a swelling and a dysfunction of the heart that happens. It's stress-induced. It's related most likely to the stress hormones that are released during those very acute, horribly stressful events. Happens to women more than men, and usually they're really healthy before it happens. If they don't die from it, it'll actually resolve in a week. But you can see it on an echocardiogram on these patients. So they usually present themselves to the ER with symptoms of a heart attack, chest pain, shortness of breath, difficulty breathing. Yeah, it's interesting. Okay, so I just wanted to talk really quickly about risk factors for heart disease. Smoking is the leading cause of premature death. Obviously, if you quit smoking, that's amazing. The benefits of quitting smoking physically are present within months, and you essentially end up looking and acting physically like someone who hasn't smoked within a matter of years. Obesity, of course, is quickly becoming the #1 cause of premature death. High blood pressure, bad. Bad cholesterol, bad. Not being very physically active, bad. So the recommendations are moderate intense exercise, 150 minutes a week, or vigorous exercise, 75 minutes per week. Even if you think I can't do that. If you can briskly walk 20 minutes a day, it produces a significant benefit on your risk of heart disease. All right, nutrition and fitness. So fruits and vegetables, obviously, really good for you, right? Fiber, good for you. Foods with a low glycemic index. Well, when I was preparing this, I thought, well, what is that? I'll show you that in a minute. Monounsaturated fats are way healthier for you than trans fats or saturated fats, and omega-3 fatty acids, very good for you. This is a nice chart of low glycemic index foods. You want to go green rather than red. So everything that's on the green side is way better for you than everything on the red side. Again, if you guys want this slide, I'd be happy to pass it on. Nutrition and fitness, again, obesity is like a big deal. So on the left, we've got what the country looked like in 1994. So the dark blue is, 15 to 19% of the population was classified as obese. And the light blue, we're talking 10 to 14%, and now here we are in 2009, and Colorado's pretty much the only one hanging out. That's Colorado, right? Everybody else is not doing so great. We're at least not the worst. Okay, so this is a chart trying to signify obesity and BMI. So BMI, like we talked about before, is the relationship between height and weight, body mass index. And a lot of your risk factors for everything like heart disease and diabetes and everything like that can really be brought back down to your body mass index. So if each one of these women is 5'5", the normal weighted woman is 111 to 150 pounds. If you weigh more than 150 pounds, you're already overweight. If you're 180 pounds or more, you're obese. And if you're 211 pounds or higher, you're really obese. This is another chart or another way to look at it. You want to be green. So I'll just throw it out there. I'm still postpartum. So I'm 5'6", I weigh 145 pounds because I can't seem to lose my baby weight. So that puts me at a BMI 23. So you can kind of see how you can see your height and weight relationship on that scale.
I want to be 23.
I want to be 21, but that's okay. All right, so here's another good slide. I put this website down here at the bottom because you know how a lot of times you Google things looking stuff up and then you wonder, is that a legitimate resource? This is a great website. I mean, this is not necessarily a medical website, but I loved it. I loved all the information that was on it. It was very helpful as far as calories and like breaking down foods and what amount of protein and carbs and sugars were in each item. I truly meant to print these out for you guys before I came here, and I apologize for that because I thought these would be good ones. But so you can see here in this chart for women, you want to have about a 2,000 calorie diet, 45 grams of protein, 230 grams of carbs. What does that mean? I don't know what that means. So here is some samples. So a 6-ounce steak has 46 grams of protein, and this is for the record for 24 hours. 1 egg has 6 grams, half a cup of cottage cheese. Who knew? Who knew cottage cheese has that much protein? I didn't. 8 ounces of Greek yogurt, 23 grams. Holy cow. That's a lot. And then carbohydrates, 1 bagel has 60 grams, a hot dog bun, 20 grams. You can see the list. That website down here has a ton more. I just listed a few. Okay, this is essentially a cartoon version of what I just said. I don't know about you, but I tend to make my meat and fish, etc., the vast majority of my plate, and then I have a little bitty space for maybe a slice of bread and some vegetables. Really, it should be the other way around, right? Fruits and vegetables should be taking up a third of your plate. Carbs should be taking up a third of your plate, and then a little bitty piece for meat and fish. And even less for sugar.
Can I do a quick plug?
Yeah.
There's a couple programs here at Lakeland that I've been involved in. The LEAN program is wonderful. They give you a lot of tools. So if you're a Lakeland associate and you're looking for a program that doesn't cost a lot, but it definitely gives you a lot of tools. If I could show you from me, a year ago, I'm down, Laura knows me, I'm down 40 pounds by going through that LEAN class and just logging everything that I've logged through tools that they've given me. It's been wonderful. It really has.
And even though, we're trained to take care of female problems, for example, they don't teach me about breastfeeding in medical school. They don't teach any doctor that. Mm-hmm. But I've learned a lot from doing it myself, and I'm passionate about it. And so Bobbi's the same way about weight loss. That's not something they taught her in midwifery school, but she knows a lot about it because she's been through it herself. So we can help women in that regard as well. So life is a journey. Buckle up and enjoy it. And this is Bobbi delivering my second son and handing him to me.
That was one of the greatest days.
I loved it. It was wonderful.
Yeah.
And these are our kids.
And he's a happy boy.
Mm-hmm.
He's a happy
He
boy.
smiles all the time.
And that's my family from Ohio.
Those
And
are my
her
boys.
older boy.